diagnostic importance of IGF-1 insulin like growth factor. And then we will see the hypothalamic and pituitary diagram effect and the pharmacological relevance. It's very easy and very nice topic. And very simply, there are only hyper and hypo functions of the pituitary, so we will cover these treatments which affect growth hormone productivity, radiation, oxytocin. And again, we will explore the difference between Cushing disease and Cushing syndrome. And again, the central and nephrogenic diabetes and its pharmacological implications. So Shelby and I were saying that I was showing the pathophysiology yesterday and we will cover pharmacology now. So here is just a quick reminder of the anterior pituitary, posterior pituitary, all regulated by hypothalamic area. And the main topic we are covering in this session is growth hormone, TSH, ACTH, and prolactin, not covering the FSH and LH. And for the posterior pituitary, of course, ADH and oxytocin. Now, it is a very interesting case of a 42-year-old executive. Tara, you are reading, you are close to the big screen or small. Could you read this 42-year-old sales executive?
Okay. Gia is 42 years old, sales executive. She struggles constantly in the fight herself on being energetic and suppressed with sales projection each quarter. 3 years ago, she developed irregular menses and then completely stopped menstruating. Over the past 2 years, she has begun to feel increasingly fatigue, has difficulty rushing the lanes of airport terminals and bothered by frequent headaches. She's always had firm headache, handshake, but lately she also noticed that her wedding ring is excessively tight. Growth hormone also frustrated that she has recently had to replace her entire shoe collection because her shoe size has increased from 7.5 to 9 with a need for increased width as well. Additionally, she has noticed increased perspiration even when she is not exerting herself and increased spacing between her teeth. Concerned about her progressive cosmetic change, her lack of menses, growth hormone trying to internally search for more.
Yes, so this is a very typical presentation, and it's really eyes of this kind of patient. This case is coming from Poland. So what do you think about the condition? What do you think about she has? Obviously, it's pituitary hormone related, so it's easy to get. Which hormone she might be dealing with, which needs pharmacological control?
Growth hormone.
Growth hormone, exactly. Growth hormone. And this is 42-year-old lady, so obviously that growth, linear growth cannot be further enhanced because the bones are closed. So it is a very interesting case of interest of growth hormone excess.
Thank you.
Amy, could you read the second part of the story?
Information, it comes across a condition called acromegaly. Struck by the uncanny resemblance between her complaints and those she has read about on the internet, GR arranges to see her doctor for further evaluation. A serum insulin-like growth factor level is significantly elevated after correction for GR's age and gender, and her serum growth hormone level is 10, whatever, after an oral glucose load of 75 milligrams. A magnetic resistant imaging MRI study of her head reveals a pituitary adenoma with maximal diameter of 1.5 centimeters. These findings are consistent with a diagnosis of acromegaly due to the growth hormone secreting adenoma. After referral to an endocrinologist and neurosurgeon, GR elects to undergo transphenodal pituitary surgery. GR tolerates the surgery well, but her post-operative growth hormone and IGF-1 levels remain elevated.
Thank you. So just a few highlights. Interesting new potencies in the insulin-like growth factor. You will see in a minute because essentially this is easier to measure than growth hormone in the serum. Second is a tenfold increase of growth hormone, so that's major issue. For the latecomers, Navarro and Portman, so we are dealing with pharmacology of pituitary. And this is an interesting case of acromegaly, adenoma producing excess of growth hormone in the pituitary. Now, she has a lesion of 1.5 centimeter, 50 millimeter. This is microadenoma or macro?
Macro.
Macro, absolutely. And this is predictable because if this would be micro, 1 centimeter less, she would be treated with which drug?
Radiation?
No, less than 1 millimeter, 1 centimeter. So there is a drug for that. We mentioned yesterday. Which is a natural product which inhibits. Which one? Bromocriptase, which is dopamine agonist. So dopamine is a natural inhibitor of growth hormone. If this would be 10 millimeter or less, then she would be treated with bromocriptase. I see this is larger, so neurosurgeon has to go in and transphenolidal, meaning that they don't they open that scar, they go into the neck. It's not an easy surgery, but it can be handled. So it is the insulin-like growth factor reminder. Insulin growth factor is called somatogenetic C. It's similar to the molecular structure which plays a role in childhood growth and has another effect in the past. And this is an important mediator growth hormone which mediates the anabolic and growth hormone together with the hormone. And it's much easier to measure in the blood and more relevant to measure because this is produced in the liver, and this actually is the mediator of factor of growth hormone. So easier to measure, that's the reason that this patient has been experiencing this much elevation of serum IGF-1. Anna, could you read the third part of the story? Can you read it?
Based on the continued elevation in serum growth hormone and IGF-1 levels, GR's endocrinologist recommends medical treatment with octreotide. GR tolerates the thrice daily injections well, except for occasional mild nausea. After 2 weeks of frequent injections, GR switches to a long-acting depot form of octreotide that is injected once a month. GR is much happier with the reduced frequency of drug administration, although she continues to experience mild nausea and bloating as adverse effects of this medication. After 6 months of depot octreotide injections, GR's growth hormone and IGF-1 levels remain elevated. GR is frustrated at the lack of improvement of her biochemical assays, but does feel that she has more energy than before treatment, and her menses have resumed. GR's endocrinologist recommends treatment with pegcetacoplan as an alternative medical approach to treating the effects of her elevated growth hormone levels. GR begins daily injections with pegcetacoplan. 6 months later, GR's IGF-1 level is in the normal range. GR is again flying around the nation in pursuit of increased sales, and she stops in town just long enough to complete her yearly head exam for function tests.
Thank you. That's a really success story, real success story in medical sciences and pharmacology and pharmacy intervention. And all these, both growth hormone and prolactinomas, are treated relatively easily. Again, because it's smaller than 1 centimeter, just chemotherapy. And second, if it's larger, unfortunately, they need to be removed surgically. So, just one other thing, what is octreotide? Probably never heard about that in pharmacology. This is actually a long-acting version of somatostatin. This is a very active drug, and somatostatin is the PAM inhibitor. It inhibits everything under the sun. There's one exception which we are not going to also. And why is the serum levels appropriate to screening of omega? Because it's easier to measure, and it's actually the active component of growth hormone is produced in the liver. What anatomic hormone conservation is by the adverse cessation of menstruation, obviously because it's endocrine disturbance, and how to act that lowering IGF levels, because again somatostatin inhibits growth hormone, the growth hormone directly, and of course the less growth hormone produced in the pituitary, less IGF produced in the liver. So we go to class because again I told you yesterday we have less hours, less time for this year covering this topic. So what are the major inhibitory factors? Just to remind you that without the pituitary cells, either producing somatotropic growth hormone, stimulating factor is ghrelin, inhibitor is somatostatin. And the major targets, of course, cardiologous insulin-like growth factor. Lactotrope, producing TRH, natural antagonist to dopamine. But again, look at somatostatin is the bad inhibitor. It inhibits everything under the sun except cortical CRH. And the target organs are obvious. You can review it later if you want. The target organs are, and the feedbacks are similar with all the organs, the positive and negative effect. Stimulators come from the anterior pituitary, either ACTH affecting the adrenal cortex or growth hormone, which are stimulated by ghrelin, inhibited by somatostatin, producing the liver to produce IGF, which is the active component of growth factor. And it is the excess, but it's inhibited, but it's increased, but the major component with the growth hormone is always there. So what are the deficiencies and excesses? The pharmacologic relevance of this is the somatotropin, which is a recombinant human growth hormone. If it is a deficiency, you can use this derivative. And there's a recombinant variant of IGF-1 also, which is megasomatic. Excess, of course, produce usually adenomas, and adult as this patient demonstrated is acromegaly. If it is small, less than 1 centimeter, pharmacotherapy. If it is larger, surgery or radiation. Somatostatin, again, the natural somatostatin is short life, so that's the reason we use longer derivatives, the octreotide. Paclitaxel is also known for Cushing disease, and peglisomab with the growth hormone receptor. So this is the simple pharmacological relevance of hypothalamic growth hormone diseases. Prolactin is a special issue. Again, reminding from yesterday, prolactinomas are the most frequent pituitary adenomas. Prolactinomas are the most important. Then comes the ACTH producing adenomas and prolactinomas. The pathophysiology of this, that TRH also stimulates prolactin secretion. So it's not that specific, does not only than TSH. And the tonic, prolactin is actually the tonic inhibition by hypothalamus by the natural dopamine. Not norepinephrine, but dopamine. Drugs like phenothiazide, antipsychotics, and metoclopramide with dopamine antagonists that actually increase prolactin secretion, because essentially dopamine agonists, antagonists, they knock out the effect of dopamine. And the pharmacological excess of prolactinomas, bromocriptine, is the standard treatment nowadays for prolactinomas. It's a relatively long-acting dopamine agonist. There is also carbapenem in the United States and Guinodolide in Europe. The adrenal axis, of course, is other frequent tumor of the ACTH cortisol interaction. In Cushing syndrome, There is an excess production of ACTH because of pituitary adrenocortical adenomas, and if you have too much cortisol, ACTH by feedback is reduced. Cushing disease is when the adenoma is in the pituitary and stimulates excess cortisol. There could be an ectopic ACTH producing tumors which are located usually in the lung, producing ACTH, and it creates a Cushing syndrome similar to the adenomas. So what are the diagnostic relevance of this anteropituitary hyper or hypofunction of ACTH? If it is hyperfunction, obviously ACTH usually produced by ACTH secreting adenoma, and the diagnostic relevance of this is you have to inject CRM and how it affects the blood levels. Ectopic secreting is constant and autonomous. They cannot be regulated by or modulated by CRM injection. It's usually requires surgical resection, and the medical pharmacologic treatments include mediraton, ketorone, or maltodextrin. These are all inhibiting adrenal steroidogenesis at various steps of the synthesis. Mifepristone antagonizes peripheral cortisol receptor. Pasilotype is a somatostatin analog that reduces blood cortisol by hyperglycemia as a side effect. The ACTH, if there's an insufficiency of ACTH, corticotropin, which is a synthetic analog of ACTH, actually shorten the normal ACTH about 35 amino acids. This corticotropin are at 24 amino acids. There's interesting drug here in the adrenocortical pharmacology. Mifepristone antagonizes cortisol. Is this specific for cortisol? What is the other action of mifepristone?
Abortion.
This one?
Abortion.
Yes, so smart lady. How has it that why it causes abortion?
It has to be used in combination with, there's another medication.
What is the other hormone that is not taken by mifepristone?
What was the question?
What is the other hormone antagonized by mifepristone?
Progesterone.
Because as I said, it is involved in abortion. But what is the other hormone?
I think it's progesterone.
Which are the two hormones that play a role in pregnancy? Which one? Progesterone and estrogen. Estrogen. Estrogen is a short because it has no two carbons at the top. Progesterone is very similar to cortisol. So it antagonizes progesterone. So we are not supposed to talk too much about abortion, but you should know that the application of mifepristone, it is used initially for antagonism of glucocorticoid and more importantly, nowadays in abortion. Is this sufficient? What is the other drug if you need to cause chemical-induced abortion? Which one? Misoprostol. Why? There are PPs and MM. Progesterone antagonism, and what is that misoprostol doing? Misoprostol is a synthetic prostaglandin. So what does it do with the uterus? Because it's not enough to stop the pregnancy. If the baby stays in the uterus, you are in big trouble. Yeah, you have to push it out. Smooth muscle contraction. Misoprostol is the prostaglandin antagonist contracts the uterus and pushes out. So, because this will be, you will face mifepristone more frequently in your pharmacy practice than using for antagonist or glucocorticoids. So this is the medical abortion. We are not supposed to teach it for various reasons, but at least you have to know about it. MM, because it's either mifepristone or misoprostol antagonist, prostaglandins, or progesterone. The pituitary, posterior pituitary axis are of course deficiencies are the diabetes insipidus, which are deficiency of ADH. And the central diabetes is controlled by lack of ADH, of course, or unresponsive receptors to ADH. Desmopressin is the exogenous ADH or analog. The nephrogenic diabetes pharmacologic implication is that the kidneys don't respond normally to ADH. So you have enough ADH, but the kidney is not responding. There is drugs for this, for treatment of diabetes insipidus, lithium, but you should know that the drug toxicity of other effects, other drugs, and we discussed yesterday that how to monitor kidney function. And amyloid and other chlorotides are used also. There is a so-called syndrome in inappropriate ADH syndrome, which is called SIDH, and this is the excessive secretion of ADH. And this, of course, is measured by result in increased plasma volume and osmolarity. And it's related, of course, ADH. Ectopic secretion by small cell carcinoma. The treatment for this is covinapron and tolvaptan and Dr. Suriyan will go over these things much later. So the big summary of this short review of the pituitary pharmacology, please remember the case of this whole senior executive. And this is a very real story, and that's the reason I'm calling your attention. Just watch, observe, and ask questions, because patients do get this adenoma, and we question you why I have menstrual problems, why I have the larger shoots than normal. So that means that most of the pituitary diseases are easily recognizable and treatable, and you are in the treatment line. Drugs for please remember that drugs for acromegaly, Cushing disease, and carcinoma, because these are the three most frequent. So know the antagonists for each of them. Drugs may cause endocrine diseases. Other drugs not related to endocrine system, but they cause endocrine diseases like the nephrogenic diabetes insipidus. And no definite differential diagnosis between diabetes insipidus and diabetes mellitus. Diabetes insipidus due to what? Which one more? ADH. And diabetes mellitus?
Insulin.
Insulin. Diabetes mellitus. Insulin. Either not enough insulin produced an endocrine pancreatitis this next week or the week after, or you have enough insulin